think, Irene, I can start by answering the ones from the last session.
Yeah.
And I see there are several questions, of course, in the chat. Maybe since you are helping us to check there, you can see which ones we can answer in the remaining time. So one question which was voiced by Sebastian was why are we seeing a lot of lung cancer in females, of course, without a lot of smoking? We think it is their high exposure to smoke, indoor air pollution from smoke, which could be causing this as a unique factor. As we know, women are more exposed. This is what we think now. Then someone had talked about the chest X-ray. I think Margaret answered this very well. However, we must distinguish between screening and early detection. In patients who are already seeking care, already with the symptoms, there is something growing in the lungs. So you could easily pick it with an X-ray, but we appreciate that we need to make CT scans more available. So if you combine the X-ray and the clinical assessment, you should be able to suspect lung cancer and order for more investigations. So those were from the last session. I think I will stop there. Margaret didn't answer. This one is a good one. People thinking that the CT scan instead of expose you to radiation and you get lung cancer in the process of screening for it. Margaret, why don't you dispel this misconception?
Thank you very much, Prof. The effects of radiation on the body are two. You have the stochastic effects, which it's just chance. When radiation goes through the body, it causes some changes within the chromosomes, and in the recombination, things can recombine wrong. That is just chance. It can happen to you while you walk in the sun because you receive more radiation from walking in the sun than from a low-dose CT. But also there are deterministic effects which come from receiving a lot of radiation. And that's why I labored to give you the doses of radiation that you receive during a screening low-dose CT scan. You only get 1 millisievert. And yet, if you come to do a normal routine chest CT scan for other things, you're going to get about 7 millisieverts. So yes, I cannot say that you cannot get the stochastic effects because that is just chance. But in terms of deterministic effects, the doses are so small that really you're not going to have. Hello, sorry, I forgot to unmute. Sorry. That the effects of radiation on the body are two. They are stochastic and then they are deterministic. Stochastic effects occur by chance. It means that if you walk in the sun, you might get something. You have a lot of radiation coming from the sun. And the effects, the radiation that you get from the sun is even more than what you get from a low-dose CT scan. That's why I labor to give you the doses. You get 1 millisievert from a screening CT scan. And when you walk into the radiology department to get a routine CT scan, you get 7 millisieverts. So the chances of getting effects from this radiation, yes, the ones of chance happen and we can't really determine who, but the doses are so small that really the risk is negligible. Then the deterministic effects come from high doses of radiation, which we do not experience in diagnostics. We only get those very high doses during therapy. when you're treating something and trying to burn it with radiation. So in terms of radiology, just checking up, the doses that we give are very small. The chances of them affecting the body are not zero, but they are negligible. Thank you.
Thank you so much. We have some more questions from the chat. This is from Vicky, who is asking if persistent GERD is a risk to getting lung cancer, and also if HPV infection is also a risk for lung cancer. The other question is about the effectiveness. How effective is cytology on pleural fluid, especially blood stained? I think we're asking how effective in getting a diagnosis when you're using pleural fluid. And the other question, okay, Dr. John's question has already been answered. We have some other questions. Someone saying, thank you, Dr. Kirenga. I think this is about the risk, why women are more at risk. I think that has been answered. Then there is a comment on the role of cervical lymph node biopsy in the diagnosis of any of the types of lung cancer. Refer guidance for suspected lung cancer patients outside the Kampala region. So I think the first two questions can go to Prof. Kirenga, then this other question can go to Dr. Okuku. Prof, you can take on the first two questions.
That was HPV and the persistent GERD.
Yes.
Of course, many viruses are oncogenic, but we don't have enough data that HPV is an oncogen for lung cancer. Maybe Freddie will comment on that, and Nixon. Then the one of GERD. GERD causes airway irritation, causing obstruction, also no clear link with lung cancer per se. But we know the seepage of gastric acid and regurgitation of acid to the esophagus can seep into the trachea and the large bronchioles and cause an asthma-like syndrome. But whether that may eventually cause lung cancer, the data is not available. Thank you.
Thank you. Prof, the other question was about if someone can use pleural fluid for cytology, how effective is it?
This is a pathology question. I can't authoritatively answer it. I can only tell you from what I have seen as a clinician, is that if you take large amounts of pleural fluid, you can see malignant cells in them, but also you need to think through the pathophysiology of the effusion. Some effusion in lung cancer is due to obstruction. Others are due to inflammation, which is remote from the tumor, but other effusion are due to direct spread of the tumor into the pleural space. The latter, you can easily catch the malignant effusion. In the first two, actually, may only get an inflammatory picture without malignant cells. And that's why you see, even when the pleural cytology is negative, if we drain the effusion and see a focal mass in the expanded lung and the biopsy, you find it is cancer. Over. But we miss having the pathologist here to give more information.
So, Bruce, I just wanted to comment on just one aspect of HPV and lung cancer. So there's no evidence that HPV causes lung cancer. There have been a few studies that have been published that have found HPV 16 and 18 in some lung tumors and tissues, but there is no causative link between lung cancer and HPV, although of course it's still an area that's open for investigation, but currently there's no causative link. And then regarding cytology, the answer is, like you've rightly said, it's a yes and no answer. That when you get the profusion, you're likely you'll be able to find malignant cells, but it's unlikely you'll be able to make a conclusive diagnosis from the profluid. You can do other ancillary studies on the profluid, but usually after the profluid, somebody will ask for a biopsy, or they can do genomic studies on blood, like Fred was saying, to make the conclusive diagnosis.
Thank you.
Thank you, Dr. Nixon. You're the best person for this other question. We've just talked about HPV, and there's a question here about the role of cervical lymph node biopsy in the diagnosis of any type of lung cancer. And also you could talk about the referral, guide on referral for suspected cancer patients who are outside Kampala.
So we'll start with the last one of suspected referral. Suspected referral patients can be directly referred to the Cancer Institute. Unlike in the past, we no longer require histologic diagnosis to admit patients to the Uganda Cancer Institute. So suspicion is enough, and we do the investigation here within Cancer Institute and Mulago Hospital Complex to establish the diagnosis. If it's not cancer, the patient is referred to the appropriate care unit to manage. And of course, somebody has just posted that if somebody deteriorates from the community, the answer is yes. If you deteriorate from the community, as a rule, you go to the nearest health facility for first aid to be stabilized before referral to the Cancer Institute or to another tertiary care facility. Regarding cervical lymph nodes, it is not best practice to make a diagnosis on cervical lymph nodes. You'll find malignant cells or invasion or effacement of the nodes, and usually you have to actually find the primary where the metastasis is coming from. Remember, there are very many cancers that metastasize to the cervical lymph nodes, including breast cancer. And also breast cancer, so of course, if it has gone to the lungs, also cause the proeffusion. So usually you have to get the primary as well.
Okay, thank you. We have some other question about the median age for women, if it is different from that for men, given that women have a higher incidence. Then we have a comment here or concern from Mr. Semper asking, they have a kid who has a persistent cough for close to 2 months, tried several mild hospitals and mango, but no results. It is deep cough and a deep voice. Maybe Prof. Kirenga will respond to that. And we have something about management. I think Dr. Cook will be the best person to respond to this. Is it possible for patients who have mixed mutations? How does that impact management? Yeah, so she's asking, is it possible for patients to have mixed mutations, and how are those managed? And yes, we also have Dr. Frank Mugabe. Yes, you're very much welcome from MOH. He's asking, what can we do to prevent lung cancer? And what are the chances to get a cure or total eradication of lung cancer? How can lung cancer be detected easiest, and what are the survival chances? We can start with Dr. Kuku.